Hello, my name is Ed McElroy and I'm currently working in the intensive care unit at the North Shore Private Hospital, and I'm going to talk to you today about airway disasters in the intensive care unit and the findings of the NAP4 audit. So I'm going to talk to you about what is NAP4 and how it applies to airway management in the intensive care unit, the lessons we can take from it, and namely preparing for failure and the use of end-tidal CO2, and I'll attempt to summarise some of their findings at the end. So what is NAP4? Well, NAP4 was a national audit project undertaken by the Royal College of Anaesthetists, and they looked at all the major airway disasters in the UK over a period of a year, and they defined a major airway disaster as an airway complication leading to death, brain damage, a surgical airway, or an unexpected ICU admission. And they found 184 cases and looked at them in depth. So NAP4 looked at the locations where the airway disasters were taking place, and ICU accounted for a large proportion of these, 20% in fact. ICU patients tended to fare badly when disasters took place, with 61% resulting in brain damage or death, compared to other areas of the hospital where airways were being regularly instrumented. So why is ICU performing so badly? Well, one cause may be the comparatively higher proportion of tracheostomies found in the intensive care unit. Tracheostomies tended to have poorer outcomes when they were lost, and indeed tracheostomies were involved in 70% of ICU disasters, with 60% of these resulting in death, so tracheostomies are potentially high-risk airways. There are also patient factors. ICU patients are sick, they have a decreased physiological reserve, and they may have an underlying shunt which makes pre-oxygenation prior to intubation difficult, and they tend to desaturate quickly when the airway is lost. They may be in ICU due to being trauma patients, making their airway difficult. They may be ENT patients with a large mass sitting next to the airway. Or they may have had previous airway instrumentation, which has resulted in swelling or edema, making further airway management very difficult. There are staffing factors. Theatres have anaesthetic technicians and anaesthetists walking around who are very competent and au fait with difficult airways. And conversely, ICU may be staffed by junior medical trainees with little or no airway skills. Increasingly, staff specialists or consultants may be from non-anaesthetic backgrounds, so do not have some of the high-level airway skills needed for these airways when they're lost. And out of hours is junior staff who are generally looking after these airways by themselves. Equipment was highlighted in NAP4, and the non-use of end-tidal CO2 or capnography being singled out as the major contributing factor to disasters, and this comes up time and time again with NAP4, and I'll expand on this shortly. In addition, poorly equipped airway trolleys, and add to this that ICU patients have difficult airways that may make simple airway rescue methods such as LMAs or bag masking untenable. So end-tidal CO2, it's a major theme that comes out of the NAP4 as a whole, but particularly highlighted in intensive care. It's standard to theatres, but it's still to make the crossover to intensive care, and NAP4 estimated 77% of ICU deaths were due to major airway disaster with failure to recognise the loss of an airway, with capnography absent in all cases. It could be argued that these could have been avoidable deaths if end-tidal CO2 had been used. The ICU environment is hostile. I put this picture here to highlight to you that if this man lost his airway, he'd have to jump over a whole load of machines and wires in order to get to it and pull the bed out from the wall, and I think you'll agree it's not an ideal intubating environment. ICUs also tend to be the victim of hospital geography, so are miles away from operating theatres should a surgical airway be required. So what did the NAP4 ICU cases reveal? Well, most were a failure to recognise airway loss, be it during intubation, during cares, or the accidental esophageal intubation. Nearly all were without end-tidal CO2. 3 were on transfers, and I suppose I'm telling you nothing new there. Transfers have always been inherently dangerous. And 46% of disasters were outside of normal office hours, when ICUs are generally staffed by junior colleagues with little or no airway training. 22 cases were due to accidental airway removal. So this is when ICU patients were being moved either on transfer or during routine cares, i.e. for bed sores or simple airway care, and this is when the airway was lost. And 14 of these were removal of tracheostomies, and as we've already established, these patients don't tend to fare well. 47% of disasters were in obese patients, and cricothyroidotomies have a tendency to fail. If you're thinking you need a cricothyroidotomy, you really need to be considering a surgical airway. So I touched on it briefly, but obese patients are really high-risk airways across the whole hospital, but particularly in the ICU, and particularly if they have a tracheostomy. NAP4 has identified them as a high-risk group everywhere though. ICU patients are constantly being moved either for transfer or cares, and therefore they're at higher risk of losing their airway. So NAP4 identified the need to have the right practitioner with the right equipment and the right preparation. So if you lose a difficult airway, you need to be contacting the anaesthetist. Your trolley needs to have all the equipment that he or she might need. A fibroscope, for example, even if you don't know how to use it, it needs to be there, and I'll expand a bit further on preparation. So if you're on the ICU ward round and you spot an airway that you think might be difficult if it was lost, you need to ask if there's a plan for that scenario, and if there's a plan B for that if that scenario fails. Make sure you have the equipment for all those plans and the staff on hand to institute those plans if need be. And if you made a plan, there's no point making a plan if you don't tell someone about it, so hand it over. So what were the NAP4 recommendations? We need to be using end-tidal CO2. It's clear that delay in diagnosing lost airways costs lives. You should be using it at least when you're intubating, when you think you've lost the airway, but there is a good argument for using it at all times with intensive care patients. And if you're a junior airway practitioner, you should be following preset plans or algorithms, and if you think you're out of the depth, you should be calling for help early. We need to plan for failure so you can avoid it. Transfers are high risk and there's nothing new there, but if you're going to be on transfer, have a good look at the airway, think about the equipment you might need if the airway is lost, and make sure you plan for failure. And staffing, we're going to have junior medical staff on take. We need to make sure that they're well trained or have readily available help nearby if they need it. And if senior staff predict a difficult airway, you need to make sure they provided for an anaesthetist to be there should they run into difficulty. So in summary, ICU is a hostile environment, not ideal for airway management and full of potentially difficult airways. NAP4 has shown that failure to plan for failure will lead you there, so spot a difficult airway and have a plan. Familiarise yourself with the equipment you'll be using, but if you take nothing else away from this talk, you must be using end-tidal CO2. It will help you identify the lost airway quickly and it saves lives. So that's it. I hope it's been helpful. My name's Ed McElroy. These are my references and thanks for listening.